Welcome to Moving Medicine, a podcast by the American Medical Association. Today's episode is part one of a two-part series hosted by Dr. Willie Underwood, immediate past chair of the AMA Board of Trustees. He's joined by a panel of experts to talk about what needs to be done to address the maternal health crisis in the U.S.
Hello, everyone. I'm Dr. Willie Underwood, Board Chair of the American Medical Association and urologist from upstate New York. And it's my pleasure to be hosting for this wonderful session. We're going to take an in-depth look at the maternal and mortality crisis in America. So given the remarkable advancement in science and medicine over the last 30 years, it is shocking that women in the United States are at greater risk for pregnancy-related deaths today than in the 1990s. And the mortality rates for Black women is, in fact, significantly higher. Black women are 3 and 4 times more likely than white women to die from pregnancy-related causes. Indigenous population are 2 to 3 times as likely. At the root of these disturbing statistics are widespread disparities that exist across our healthcare system. Limited access to care for historically marginalized groups, chronic disease, a lack of pre- and postnatal care, and implicit bias on the part of clinicians have all contributed to this, as well as many other factors. In fact, our nation suffered from the highest rates of mortality than any other well-resourced country. What's most disturbing is that a significant majority of pregnancy-related deaths in our country are preventable. So that's why we're here this afternoon, to raise an alarm about these concerning trends, and to talk about what potential policy solutions could and should look like. And let's jump right in. Jennifer, I would like to start with you. What is the current landscape of maternal morbidity and mortality in America? And what are some of the factors driving these trends?
So thank you, Dr. Underwood. You mentioned that Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women. And American Indian and Alaska Native women are 2 to 3 times more likely to die than white women. We know that Medicaid covers about 43% of all births in the United States. However, almost 66% of births of Black women and 67% of births of American Indian and Alaska Native women. More than 90% of women deliver in a hospital, and about 80% of these deaths are preventable. However, this heightened risk, specifically for Black women, spans all income and education levels and insurance types. And I just want to ground our conversation by saying that these are not just statistics. Each tragic death matters, and it matters to the spouse, the partner, it matters to their family, it matters to their extended community. And we know that severe maternal morbidity affect approximately 50,000 to 60,000 birthing people each year. And the numbers are increasing. And as some of you may know, I am so passionate about this issue because I almost died during my second pregnancy due to a uterine rupture. I was about 7 hours away from bleeding to death. So I take this issue to heart, and I'm very passionate and very committed to making sure that the AMA addresses this problem. We know that birth inequities, as you mentioned, arise at the intersection of discrimination by race and gender. For Black and Native American women, we're talking about closures of maternity units in rural areas as well, and urban areas as also major factors. In addition to discrimination and bias and OB unit closures, which you mentioned, we know that some of the most frequent underlying causes of pregnancy are related to cardiac and coronary conditions, hemorrhage, infection, sepsis. So these are I just wanted to lay the foundation and lay the groundwork for what we're talking about.
Thank you. So Michael, as Jennifer just mentioned, cardiovascular disease related to maternal mortality. So what impact does hypertension have on birthing people's health? And what are some specific areas in which you think we can improve the care and related to hypertension that birthing people receive during and after pregnancy? And what is the AMA doing to help improve the care of patients with hypertensive disorder of pregnancy?
All right, thanks, Willie. Well, before I answer those questions, I want to quickly define the 4 categories of hypertension disorders of pregnancy, just so everybody understands, and in case we have people who may not be as familiar. Chronic hypertension is hypertension diagnosed before or in the first 20 weeks of pregnancy. Gestational hypertension is new onset hypertension that occurs after 20 weeks gestation. Preeclampsia is hypertension that occurs after 20 weeks with protein in the urine or low platelets or other organ involvement, and this can progress to eclampsia if seizures occur. And the 4th category is chronic hypertension with superimposed preeclampsia, where preeclampsia occurs in a patient with existing hypertension. So those are the 4 categories. It's important to recognize that these disorders are common. As Jennifer mentioned, they occur in nearly 1 in 7 deliveries in hospitals, and they're increasing. The number of people entering pregnancy with chronic hypertension nearly doubled between 2007 and 2018. And importantly, as Jennifer also mentioned, stark racial inequities exist, with Black, American Indian, and Alaska Native birthing people disproportionately affected. So what's the impact on hypertension on birthing people's health? Well, the potential consequences of hypertensive disorders of pregnancy are that they're a leading cause of death in the early postpartum period, particularly in the first 6 days, where they're literally the second leading cause of death in days 1 through 6. Hypertension is the leading cause for 30-day readmissions postpartum. And people with hypertensive disorders of pregnancy have high risk of developing chronic hypertension and cardiovascular disease long-term. The risk of developing hypertension long-term is 2 to 3 times higher. The risk of developing cardiovascular disease is nearly double. And I think it's also really important to note that people who have a hypertensive disorder of pregnancy have shorter lifespans. So all really relevant and important information. So what can we do to improve the care for birthing people with hypertensive disorders of pregnancy before, during, and after pregnancy? Before pregnancy, focusing on prevention and diagnosing conditions that lead to increased risk is critical. So things like making positive lifestyle changes to prevent hypertension, focusing on nutrition, low sodium or salt intake, being physically active, and tobacco cessation, including e-cigarettes, all extremely important. And these are all factors that contribute to optimizing cardiovascular health, as is diagnosing and treating existing hypertension, which we need to improve on, and diagnosing and treating other medical conditions that can lead to poor cardiovascular health, like obesity, diabetes, and high cholesterol. So that's before pregnancy. During pregnancy, focusing on monitoring, diagnosing, and treating these conditions. So monitoring blood pressure throughout pregnancy, both in office and remotely, and using patient safety bundles of best practices like the AIM bundles, which Jennifer's going to go into more detail, are imperative for effective management with more equitable outcomes. And using aspirin after 12 weeks gestation for those at high risk for preeclampsia to reduce preterm birth. That's during pregnancy. After pregnancy, continuing to monitor people closely and intervening quickly when indicated. This includes blood pressure monitoring starting immediately after discharge, initiating and titrating medications when indicated, and importantly, transitioning to a primary care physician for follow-up and long-term monitoring. And throughout all these phases, before, during, and after pregnancy, education and support for both clinical teams and patients is essential. We need to provide education to physicians and clinical teams on the most current evidence and guidance, including all specialists involved in the care of these patients. And increasing access to telehealth services is extremely important. And for patients, campaigns like the Release the Pressure campaign, aimed at improving heart health for Black women, education on home blood pressure monitoring or self-measured blood pressure monitoring and how to perform it, and awareness of the risks of hypertensive disorders of pregnancy, symptoms, and when to seek care. And, Willie, for the third question, what is the AMA doing to help improve care for patients with hypertensive disorders of pregnancy? In the AMA's Improving Health Outcomes group where I work, we're working in 2 key areas: clinical quality improvement and multidisciplinary collaborations. For clinical quality improvement, we're focusing primarily on postpartum because 2/3 of the mortality in patients with hypertensive disorders of pregnancy occur in the 12 months after delivery. All healthcare professionals, as I already mentioned, working with patients during that time need to be familiar with the ongoing risks and treatment recommendations. And this provides us with an opportunity to impact both short and long-term health. And as for multidisciplinary collaborations, and this includes with clinicians, healthcare organization leaders, advocacy, and community-based organizations, we're convening experts to identify practical and effective clinical interventions to improve care for patients with hypertensive disorders of pregnancy postpartum. We're learning from healthcare organizations who are already developing and implementing their own interventions. And we're collaborating with these healthcare organizations, researchers, and experts from organizations like the CDC, ACC, the American College of Cardiology, and ACOG to better understand opportunities and elevate existing resources. And the intent of all of these efforts really is to identify what works and then focus on helping to scale those effective interventions.
Wow. So we know that when we look at the total health of the human being, there is a financial or economic perspective to it. There is a physical overall health with chronic disease, right, aspect to it. So we've somewhat touched those. So now, Maryanne, please include what is the role of the mental health in pregnancy and postpartum period, and how does mental health contribute to maternal morbidity and mortality? Please tell us what the AMA is doing to support the mental health needs of pregnant and postpartum women, as well as, or pregnant individuals, as well as physicians caring for these patients.
Those are such important questions, Willie. And as Jennifer mentioned in her review of the current state, we know that mental health conditions account for over 75% of pregnancy-related deaths that are predominantly due to suicide or substance overdose or mental health conditions such as substance use disorder. And from a morbidity standpoint, perinatal mental health disorders are also common, and they're a significant complication of pregnancy in the postpartum period. Up to 20% of women in the United States experience perinatal depression or anxiety. And in community health centers funded by HRSA, such as the community health center in which I work, over 40% of our female patients of reproductive age report depression. But despite this knowledge, data shows that pregnant and postpartum individuals who have behavioral health conditions are less likely to receive sufficient behavioral health care compared to those who aren't pregnant. So you also asked, Willie, what's being done to improve the mental health care for patient and postpartum individuals? Well, it's now recognized that holistically integrating behavioral health into, OBGYN care practices and settings can improve and provide a true patient-centered experience of care. This integration of physical and behavioral health breaks down the traditional care silos and helps both pregnant and postpartum individuals receive treatment earlier when they need it and hopefully at the right level of care. So knowing this information and recognizing the potential impact of an integrated care model, I'd like to mention two of the advocacy actions that the AMA is taking to help make it happen. First, the AMA has partnered with several members of the Federation of Medicine, including the American College of Obstetricians and Gynecologists, ACOG, to establish the Behavioral Health Integration Collaborative. The mission of this collaborative is to equip physicians and their practices with the knowledge and support to give integrated care to patients. To accomplish this mission, the Behavioral Health Integration Collaborative has called on payers and policymakers to join forces with OBGYNs and other physician specialties to ensure that they have the necessary support to provide that integrated, equitable, and whole person care for patients and families. And the second advocacy action the AMA Behavioral Health Integration Collaborative has accomplished is it's developed and is offering a free webinar series titled Behavioral Health Integration, which is a webinar series that specifically focuses on integrating mental health care into OB practices. Thanks.
Thank you. So I'd like to shift the discussion to the social determinants of health. Now, we know again, that the social determinants of health impact every aspect of what we were just discussing: the physical, the financial, including the mental health, the spiritual health, right? The emotional health of the individual. So when we think about social determinant health, which is the important part of the discussion, because social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of their daily lives. These forces and systems include economic policies, systems, developmental agendas, social norms, social policies, and political systems. As a result, determinants of health are often impacted by large and powerful systems that leads to discrimination, exploitation, and marginalization and exclusion and isolation. So, Jennifer, what is the AMA doing to impact how pregnant individuals from historically monitorized communities and rural communities and economic marginalized communities receive the support they need to have healthy pregnancies?
Thank you for that question. It's such an important one. We know that in this country, these historic and systemic realities are baked into structures, policies, practices, and produce, exacerbate, and perpetuate, quite frankly, inequities among the social determinants of health and therefore affect health itself. The question then is, once a physician identifies that a patient has a need, which could be a social determinant of health need, care coordination, or even just help navigating the healthcare system, then what? So we want to help patients both navigate the healthcare system and address social determinants of health by enhancing medical legal partnerships. Perinatal medical legal partnerships, MLPs, share responsibility across a diverse team, integrate legal care as needed, and leverage law and policies to help manage vulnerabilities that are exacerbated by an advancing pregnancy. Encouraging the use of medical legal partnerships in more perinatal settings is warranted, as obstetric visits often offer an ideal time to discuss and intervene. Moreover, some very successful MLPs have been established across the country. We have one nearby our office, the Georgetown University Health Justice Alliance Perinatal Legal Assistance and Wellbeing Law Project, one of the first MLPs to focus specifically on perinatal needs. These MLPs show a reproducible pathway to helping patients navigate the healthcare system and address social determinants of health. So as part of the AMA's outreach and advocacy, we are strongly encouraging both the administration and Congress to work together to provide funding, increased funding to expand MLPs across the US so that every birthing person can have access to the benefits they are entitled to ensure a healthy pregnancy.
Awesome. Maryanne, the ongoing overdose epidemic impacts all patient populations, including pregnant and postpartum patients. So what are specific considerations for pregnant and postpartum patients with substance use disorders? And what policy changes are needed to help support this patient population?
Thanks, Willie. Such a very important question. Among pregnant and postpartum persons, drug overdose mortality increased approximately 81% from 2017 to 2020. And NIH data shows that the largest increase was observed in pregnant and postpartum persons between the ages of 35 and 44, whose overdose mortality ratios tripled from 2018 to 2021. And mortality from substance use has increased for individuals who are pregnant or postpartum across almost all age, racial, ethnic, educational, and marital status groups. And there's accumulating evidence that certain social determinants of health that were mentioned by Jennifer earlier, specifically poverty and lack of adequate health care, are also associated with substance use mortality. But stigmatizing or penalizing pregnant and postpartum individuals with substance use disorder creates barriers to care. Barriers that are so significant that individuals don't seek treatment for their drug use and they don't receive prenatal care because of fear for themselves and for their families. Data shows that pregnant individuals with substance use disorder are less likely to receive an appointment to an addiction treatment center, have difficulty finding childcare to get there, and in many states face punitive policies for their substance use, including fines, loss of custody of their children, involuntary commitment, and even incarceration. But there is advocacy work going on to try to make some positive changes. There are many evidence-based programs and efforts underway in states right now to extend Medicaid and the Children's Health Insurance Program, or CHIP, to extend coverage to pregnant individuals with substance use disorders. And the AMA has urged the administration to highlight those state expansion efforts and encourage states to continue to build on evidence-based practices to improve care and reduce inequities. And this includes support for removing harmful policies that stigmatize and punish pregnant and postpartum individuals who receive medications for opioid use disorders. The AMA recently released an important document titled Improving Access to Care for Pregnant and Postpartum People with an Opioid Use Disorder, Recommendations for Policymakers. And in this document, there's a comprehensive set of recommendations that can be used for advocacy. And these recommendations are designed to enhance care for individuals with opioid use disorder who are pregnant or postpartum. And lastly, the AMA strongly, as we know, opposes criminalizing pregnant individuals who have substance use disorders. And sometimes our advocacy has had to go to court.
Now, let's bring this home to what's extremely important and significant here, because this we can fix. And this is what we're trying to solve as we think about it. So according to the CDC, 80% of maternal deaths in the United States are preventable. I'll repeat that again. 80% of maternal deaths in the United States are preventable. So Jennifer, what changes are needed to prevent these deaths, and what role should and what are the AMA plan?
Thank you so much, Dr. Underwood, for asking that question, because of the fact that 80% of these deaths are preventable, we're trying to focus on what can be scaled up nationally and what can be implemented nationally to impact pregnant individuals across the United States, whether they're in urban hospitals or rural hospitals. And I say hospitals because we know that 99% of these births are in hospital setting. One of the things that the AMA has been really focused on is elevating these core AIM bundles. And these are the Alliance for Innovation on Maternal Health, called AIM Patient Safety Bundles. And we're strongly encouraged that they're included in the White House blueprint that the administration has released. However, it is important for states and the federal government to recognize that the biggest barrier to implementing these core AIM bundles is a lack of resources, and that additional funding beyond what has already been invested by the administration and Congress is desperately needed to adequately implement the AIM bundles, especially in smaller institutions and institutions that do not have vast resources. The core AIM patient safety bundles that physician-led teams can implement to address the most common causes of maternal mortality are supported by specific quality metrics and measures through the AIM data center and are the core building blocks of the AIM program's efforts to address the leading known causes of preventable severe maternal morbidity and mortality in the United States. Because 90% of these births, whether paid for by Medicaid or private insurance, occur in a hospital setting, the AMA believes it is uniquely positioned to kind of support all physicians, including non-OB physicians delivering babies in rural and historically marginalized communities, to address these complex health issues. And we know that by working with the administration and Congress to increase funding, we can elevate this and expand this, scale this up nationally, especially for, as I said, in rural communities. These are really pivotal in the work that we're doing. And just to put a finer point on this, we're talking about obstetric hemorrhage. We're talking about severe hypertension in pregnancy. We're talking about cardiac conditions in obstetric care. We're talking about perinatal mental health conditions, postpartum discharge transition, and sepsis, and care for people with SUD. So those are some of the leading causes of deaths, and those are also piggyback on and focus on the AIM bundles as well. So we want to do both. We want to focus on both, and these core AIM bundles really elevate that work if hospitals have the resources and the infrastructure to be able to implement those and the funding.
So, Michael, so what are some policy changes that could help support improving the care of patients with hypertensive disorder pregnancy?
Well, we need regulatory and institutional policies that remove barriers. The ones we hear most often are coverage, reimbursement, and a lack of system level support. So from talking with clinical and research experts and practicing physicians, we've identified a few barriers where policy change could help quickly. And I'll just give you a few examples where we've seen some success and traction. So coverage for clinically validated or clinically accurate blood pressure measurement devices, home blood pressure monitors with no copay. So we've had some success here with commercial payers and Medicaid. We're working on reducing barriers that limit access to these devices. For example, the process that patients have to go through to obtain the device, even when there's coverage, sometimes is not clear, sometimes is cumbersome. So for example, if there's a designated DME supplier or a designated retailer, or the device is supposed to be prescribed and then mailed to somebody, these processes, sometimes they work, sometimes they don't work well. But I think more importantly, often there's a gap in the understanding of physicians and clinical teams and patients for what those processes are, even when there's coverage. So there may be some level of coverage, but it just doesn't work. So we have to find a way to make sure that that information is always understood by patients and physicians. But having said that, again, we have seen success in creating the coverage. We just need to continue to work to make the quality of that coverage better. And we also want to make sure it includes things like, while it's great to have a validated blood pressure measurement device for remote monitoring during and after pregnancy, that device has to come with a cuff that fits the person that's using it. And often the devices come with a standardized cuff that doesn't fit large and extra large arms, which are increasing in frequency in the United States. So we've got to also make sure that when there's coverage, that things like extra cuffs are available with those devices so that they can be used accurately, because without them, none of it will matter, because the cuffs won't be accurate and reliable for diagnosing and treating these conditions. Another component here is coverage for clinical support services, which is really important as well to make sure that these get used. We need clinical support services so that physicians and healthcare teams can better manage care for these patients. The other area that we've seen traction is systemic level support policies. So we have been promoting a procurement policy for clinically validated BP measurement devices that health systems can adopt and have adopted to ensure that when they procure these home blood pressure monitors, these self-measure blood pressure monitoring devices, for whenever blood pressure is measured within the organization or even at home from patients where they're providing devices, that it's measured with a device that is validated for clinical accuracy. So in other words, they adopt a procurement policy that says they will only purchase devices that have been validated for clinical accuracy.
And I'm going to tell you, so far, I've heard some very alarming statistics, and I've also heard some very awesome solutions. And I look forward to working with you to sort of move these things forward, Michael, Jennifer, Maryanne, and the rest of our AMA family.
That wraps up the first part of this two-part series. Don't miss the next part of the conversation. Subscribe to Moving Medicine today. Thanks for listening.